Good evening, everyone. Dear colleagues, friends, ladies and gentlemen, it gives me a great pleasure to welcome you and thank you for joining us in this webinar on B-cell therapy in multiple sclerosis. This is one of the educational activities of the Emirate Neurology Society, which is chaired by Dr. Suhail Al-Rukn. In this webinar, we will learn the different types of B-cell therapies for multiple sclerosis. We will understand the role of B-cell in the pathogenesis of multiple sclerosis. This webinar is sponsored by Novartis, organized by MCO, and endorsed by the Emirate Neurology Society. Thanks for all of them for their contribution. This webinar is meant to be interactive, so you are invited and encouraged to submit your questions at the Q&A bottom. You see it down on the screen, and we will be more than happy to answer your questions. This is CME accredited, so the organizers, MCO, will be contacting you in the way how to get the certificate. And now it's my pleasure to introduce our speaker tonight. You see the agenda, of course. Our guest speaker tonight is Dr. Naji Rayashi. He just recently joined Sheikh Shakhbout Medical City as a consultant neurologist and Khalifa University College of Medicine as a clerkship director of neurology and assistant dean for clinical affairs. Before joining Sheikh Shakhbout, he was professor and the chair of neurology department at the Lebanese American University in Beirut. Dr. Rayashi received his MD from the American University of Beirut. Then he did 4 years postdoctoral research and fellowship in neuropharmacology and neurochemistry at Case Western Reserve University in Cleveland, Ohio, and completed his residency in neurology at University of Cleveland. Subsequently, he joined the Cleveland Clinic Foundation for 2 years fellowship in epilepsy and clinical neurophysiology. He is board certified in neurology, psychiatry, and American board certified in clinical neurophysiology and epilepsy. He is a member of several societies, associations, including American Academy of Neurology, Lebanese Neurological Society, and founding member and past president of the Lebanese League Against Epilepsy. Dr. Rayashi has very long CV. It will be difficult to summarize it tonight, but he is involved deeply in research and publication and drug trials. He is an editorial board member of several leading journals and the author of many peer-reviewed publications and book chapters. It's my pleasure and honor to invite Dr. Rayashi to give his talk on the era of B-cell therapy. Dr. Naji, the floor is yours, please.
Thank you, Jihad. Thank you very much for your kind introduction. I would also like to thank the organizers, the sponsors, and the society for this event, and for giving me the opportunity to present this topic, which I hope you will find interesting. Let me just start sharing my screen. All right, so we're gonna get started on this update on B-cell therapies in multiple sclerosis. It is really amazing to me how much this has evolved with time. I mean, I never thought that in my lifetime we would go from no treatment for multiple sclerosis except for steroids, of course, for acute relapses, to the multitude of medications that we have now available, and that is making it hard for us to make a choice, because we really have choices to make to pick the best medication for the particular patient and to personalize the treatment. And this, the need to continue to look for new medications has come from an unmet need, because patients with multiple sclerosis at the beginning had always to compromise. They had to pick a medication that would be efficacious versus a medication that would be safe, and they would compromise the efficacy for the safety or the safety for the efficacy so far. And historically, we would start with the safest and least efficacious medication, and then we would move on slowly and escalate treatment. This used to be the pattern that we were all using to treat these patients 10 years ago, I would say, and even a little bit less than that. Whereas we have data to prove that starting on a highly efficacious medication early on would really give the patient the best outcome and the best quality of life on the long run. And starting them on a highly effective treatment would reduce the inflammation and reduce the disability and reduce the overall relapses that these patients would be otherwise prone to have with this course of MS. So from here on, the need to continue to look for newer therapies that would give us extremely efficacious medications, but that would have an acceptable safety profile, so that we would be able to use them not only in the patients that come with highly active disease and that would be at risk for a severe form of MS, but also maybe hopefully in naive patients or patients that would have mild forms of the disease. So the benefit risk associated with the established high efficacy treatments are summarized for you in this slide. And it shows all the things that you already know about the medications that were available that are highly efficacious. There are some others that are not on this slide. This comes from the EAN meeting. And I'm not going to go over the details of it, but as you know, every medication, when the efficacy would start becoming high, would be associated with a higher side effects profile that one would have to be careful about, and then what would have to monitor patients about as well. So up until recently, we really did not think that B cells had much to do with MS pathology. I mean, we always used to think that this is a T cell affair, and the B cell involvement was not clear up until a few years ago. And when we started using B cell therapy and got the huge response that we did with them, we started to think even more that there is a lot of things that the B cells would be involved with in the pathology of MS. B cells usually are produced in the bone marrow, and then they are activated in the secondary lymphoid organs, whether it be the spleen or the lymph nodes. And for them to reach the brain, they would have to cross the blood-brain barrier. And they would have to be reactive, and they would have to find their way in to infiltrate that barrier and to be able to get into the brain, where they would start producing their inflammation and the destructive cascade of events that would result out of that. Now, the rationale for targeting the autoreactive CD20 positive B cells comes from the fact that if we have a depletion of these abnormal B cells, we could affect the MS pathology via both the indirect as well as the direct effects. And I can show you on this slide 4 such mechanisms that one could think about if this would be the case. First of all, we know that the autoantigen presentation uses the B cell to present the antigen-specific cell to the T cell and to activate the T cell. So we need the B cell to activate the T cell. Second, B cells are involved in cytokine production and in the release of pro-inflammatory cytokines, which are involved in the cascade of inflammation. Third, autoantibody production would result from aberrant production of autoreactive antibodies, and that would start destroying cells, considering them to be foreign or pathological when they are not. And third is the ectopic lymphoid structures, and we can see such structure being formed in the brain of these patients who suffer from MS. Now, the interesting thing is that when we follow the formation of a plasma cell from the stem cell, not every stage is really expressing the CD20. And the CD20 is not going to be expressed in the stem cell or in the pro-B cells, and it's not going to be expressed also in the plasma cells themselves. And this will be a complex process that will that the cells will undergo when they will differentiate in the B cell lineage. The CD20 is a cell surface molecule that will be expressed on pre-B cells throughout the life cycle of the naive cells, and it is not expressed, as I've mentioned, on stem cells or on pre-B cells or on plasma cells. And this is extremely important because this will allow us to preserve, one, the B cells reconstitution, and two, the long-term memory. So by affecting these cells that are expressing the CD20, we will not affect the long-term memory, and we will not affect the cells that will help us reconstitute our B cell reserve, which is really key in this whole process. Now, we have three types of anti-CD20 monoclonal antibodies, and they would all affect the CD20. We have the first one is Rituximab, which is a chimeric molecule. It is used off-label in the treatment of MS. The second one is Ocrelizumab, which is a humanized form, and it has gotten excellent results, as we will discuss in a little bit. And the third one is Atumumab, which is going to be the subject of tonight's lecture, which is a fully human monoclonal antibody. It's not humanized, it's fully human, and hence the less injection side reactions that one would get, and the molecule can be administered without the use of steroids and without the use of antihistamines, because it is fully human and because the allergenic reaction is going to be decreased to a minimum. Now, what about the binding sites? How would the monoclonal antibodies that we saw bind to the CD20? Well, Rituximab and Ocrelizumab are going to share one epitope, okay? Whereas Ofatumumab is going to have a completely distinct binding site, and it would involve two epitopes, okay? So Rituximab will bind on the large extracellular loop, involving the loops 168 to 175, whereas Ocrelizumab will bind to region 170 to 178, so there is going to be a large overlap between those two, whereas Ofatumumab will bind to a completely different area involving both the large loop and the small loop, and it will have a very off rate, and it will deliver potent and sustained effector activity. And it's such it has such a binding site that it will be used in much smaller doses, and it will convey the same results. Now, the lymph node targeting has been tried with both subcutaneous and with IV injections. And I would like to show you on this slide that when you inject Ocrelizumab subcutaneously, it will reach the cells at a higher concentration than when you do inject it IV, intravenously. And the same will be true for Ofatumumab. When you inject it subcutaneously, it will reach the concentrations that are going to be much higher than when you inject it IV. But the difference is that in MS, ocrelizumab is given IV and ofatumumab is given sub-Q. And so this is why subcutaneous administration of ofatumumab will result in improved lymph node targeting in the mice model that was used to do these experiments compared to the IV routes. And this was determined usually by using gamma counting. So there is an advantage to using a subcutaneous infection because you can deliver higher doses to the target organs. Now, ofatumumab will induce the antibody-dependent cellular cytotoxicity in the same proportions than ocrelizumab will. And they will both have a higher activity than rituximab. Okay, and so we will have, when we incubated purified B cells with ofatumumab, ocrelizumab, rituximab, or anti-chicken lysozyme, we had higher rates of dead cells reached by using rituximab, sorry, ofatumumab and ocrelizumab than by using the other two. Now, ofatumumab will induce the complement-dependent cytotoxicity, which will result in the lysis of primary human B cell, and it will reach very high level doing that. And this is a mechanism of action which is really singly found in ofatumumab, where over a 2-hour simultaneous exposure, you will have complement activation, which will produce the cell death. So we don't need other means. We can do it also through complement activation, and this is peculiar to ofatumumab. Now, what about the B cell depletion once ofatumumab is used? Well, you will start seeing it after 1 week, actually, of the injection, but you can detect it as early as 2 weeks, and there will be no significant reconstitution in between doses that will be injected on a monthly basis. So the B cell will decrease and they will remain low for the duration, and they will not increase significantly in between doses, okay? And the proportion of patients that will have the B cells decrease to very low level will be very high, and it will reach 80% within 4 weeks of starting, 4 days, sorry, of starting the injection pattern. And it will reach its highest level at around 28 days of using the medication. So a monthly dosing will maintain consistently low levels of B cell depletion using the dose that has been recommended, which is 20 milligram per dose of ofatumumab. And there will be a median B cell depletion to less than 10 cells per microliter that will be achieved within 8 days. And as I've mentioned before, there will be negligible signs of B cell depletion in between doses. So more than 94% of the patient will reach the low B cell level required, and it will be a steady state, and it will be a pre-dose effect. Now, the interesting thing, however, is when you inject ofatumumab IV, if you were to stop it, you would not replete the cells as quickly as you would do when you would inject it subcutaneously, okay? And this graph shows you that both in the blood and in the lymph node, when you stop the treatment of ofatumumab used subcutaneously, you very quickly will reconstitute your B cells. You will get them back up within days. Whereas if you were using it IV, it would take much longer for the cells to start coming up in the blood and in the lymph nodes. So This will be extremely important because you could get a full recovery from Atumumab after you would stop the treatment for 6 to 9 months, which is very important nowadays when you want to plan pregnancy, when you want to plan vaccination, when you want to plan all of these things. And in comparison with ocrelizumab would take about double that time. So it would take about 1.5 years for a full recovery for ocrelizumab. Now, what are the pivotal clinical trials that have shown the effect of B-cell therapies? And I will start by showing you the OPERA studies for ocrelizumab, the OPERA 1 and OPERA 2 that have shown the huge efficacy when compared to interferon beta 1a sub-Q. It was shown at the level of the relapses, at the level of disability progression, MRI activity, and brain volume loss. The relapses were decreased by about 47% compared with interferon beta 1a sub-Q. The disability progression also showed much improvement with a 40% decrease at 3 months and at 6 months. The MRI activity, we almost wiped out completely the gadolinium enhancing lesions, and the new T2 lesions were decreased significantly, substantially, to a level of about 80%. And then there was also an effect positive in favor of ocrelizumab on brain volume loss. So this was all good, together with relatively very acceptable side effect profile. You all have heard about the issue of the neoplasm, but they were not shown to be significantly higher than the general population. And then also you have to watch for recurrence of herpes zoster. This is why these patients have to be vaccinated if they have not been exposed to the herpes zoster before you start them on treatment. So overall, very good results for ocrelizumab. And now I'd like to talk to you a little bit more about the studies that have shown the efficacy and safety of Atumumab. And these are the Eclipsios studies that have compared Atumumab to teriflunomide. Why the choice of teriflunomide? Because you would not want a patient to get 5 subcutaneous injections or a lot of them during if you were to compare it to an interferon. And it was nice to switch the placebo between tablets and injections. And this is why it was picked, and it was shown, teriflunomide was shown to be as effective as the interferons. So this was 2 twin studies that used the same protocol. It was double-blinded, double-dummy with an active comparator with parallel groups. So patients were at first randomized, and then they either received teriflunomide orally and the placebo subcutaneously, or Atumumab 20 milligrams subcutaneously and the placebo orally once daily. And then at the end of the study, which was flexible, there has been an extension study still ongoing, but it will keep going for 5 years to assess the safety further. Now, the inclusion criteria, they've used adults, 18 to 55 years, male or females, with a diagnosis of relapsing MS. So progressive MS was excluded. And then the interesting thing is that they have used an EDSS score of 0 to 5.5. So this was not a restrictive inclusion criteria, and the patients were very representative of the MS population that we see in our daily activities and in our clinics. And so they would have to have relapses in the 2 years before, etc. So they would have to have active forms of the disease. And then we excluded patients with neuromyelitis optica and patients that had evidence of hepatitis or tuberculosis. Now, the first treatment started in October 5, 2016, and the last patient first treatment started in March 1, 2018. And there were a total of 37 countries that participated in the study, with 385 centers that recruited patients. And they were from Eastern Europe, from Western Europe, from the US and Canada, but also from a large number of other countries that are usually not involved in studies like this, Latin America, Africa, Australia, etc., and the Middle East, in order for it to be a little bit more representative of the global population of patients with MS. Now, the groups were very well matched, as you can see, for teriflunomide and ofatumumab, both in Asclepios 1 and 2. The number of patients was above 900 patients for both studies, 927 and 955. Majority of females, as one would expect. What is interesting is that the previously treated patients with disease modifier medications reached about 60%. So we had the 40% of the patients that were included in these studies that were naive to treatment, which was another interesting twist of these studies. And a lot of them had evidence of active disease, as is seen with the number of gadolinium-enhancing T1 lesions. Now, the primary endpoint of the studies was the annualized relapse rate. And ofatumumab reached the target. It showed a significant decrease in the annualized relapse rate, both in Asclepios 1 and 2. And it reached 51% and 58% in the two studies, respectively, which is huge, because this would imply that 0.1 relapses per year would occur, which would mean one relapse every 10 patient years, which is really very, very good results for this medication. Given that the relapses would really affect the patients very negatively, and early relapses would really imply usually a more severe form and a more active progression to a more severe form or to a progressive form with time. Now, what about the MRI criteria? Were they met? As far as the T2 lesions compared with teriflunomide, you notice a significant decrease in the number of new T2 lesions that reached about 85% in the studies. So there were significantly fewer new or enlarging T2 lesions per year when compared to teriflunomide. And mind you, we're not comparing them to a placebo. We're comparing them to a medication that was shown to be efficacious in the treatment of MS. So really excellent results for the MRI picture. And the same and even better was seen when one looked at the gadolinium-enhancing T1 lesion, where they were almost completely wiped out, as was the case with ocrelizumab, to 97 and 95 and 94% respectively, compared to teriflunomide. So it was nice to see that this is happening, because the less lesions we have, the less the progression to secondary progressive MS. Now, what about the confirmed disability worsening versus teriflunomide? And here also statistically significant results were reached, where you can see that both at 3 months and at 6 months, you have about 34 and 32% reduction in the risk of converting to confirmed disability worsening, which was measured using, of course, the EDSS score. So the ofatumumab showed reductions in both the 3-month and the 6-month confirmed disability worsening that were consistent across all patient subgroups, and this data is not shown here for the sake of time. Now, as far as confirmed disability improvement, there was a favorable trend that did not reach statistical significance, but there was a favorable trend in favor of Atumumab compared to teriflunomide. Okay, and it shows here about a 35% reduction, but again, this did not reach statistical significance for improvement. What about the serum neurofilament levels? Here also we have very interesting results that panned out. Compared to teriflunomide in gray, Atumumab in blue decreased the neurofilament levels in the serum by quite a bit in both studies, Asclepios and 1 and 2, and it reached about 27 to 23% decrease with time, and it was maintained over 2 years, which is really very significant, and it would confer protection against axonal loss. Now, what about brain volume loss, brain volume changes? Well, there was no statistical significance between Atumumab and teriflunomide, but teriflunomide, unlike interferons, had shown some data that it had protected and it had decreased the brain volume loss that was noted with patients with MS with time. So this is the data here. A very interesting slide unfolds here, and this is the patients with no evidence of disease activity compared with 3 criteria during the 2 years of the study. And as you can tell, the proportion of patients reaching NIDA-3 in the second year of treatment was 9 out of the 10 patients with Atumumab, when compared to 5 out of 10 with teriflunomide. And the numbers were very significant when one compared months 12 to month 24 of the treatment, which is really extremely interesting in favor of Atumumab. Now, usually when we see such nice data, we have learned to expect a side effect profile that is not very good. This used to be the case, unfortunately, in the past for a lot of medications. But in this case, there is an exception in that the safety and the tolerability of Atumumab were extremely good, and they were very comparable to those of teriflunomide in the clinical trials. And so when you compare serious adverse event of any kind, 7.9% to 9% teriflunomide of Atumumab respectively. So this is really nice. And then the most common adverse events, so the ones that were seen in more than 10% of patients in the treatment group, were mostly the injection-related reaction that reached 20% for Atumumab compared to 15% for teriflunomide. And of note, and as we'll discuss a little bit later on, that these were usually seen after the first injection mostly, very few after the second injection, and then the rates would drop tremendously from the third one on, and that they were most commonly mild to moderate, and very, very few were severe. I will let you look at the rest of the profile. There is no raised risk of infection, and there is no new malignancies patterns that were described or higher malignancy rates that were seen. So all in all, an extremely favorable side effect profile. Now, most injection-related systemic reactions were mild to moderate. Only in 0.2% of the cases were they severe. So there were no life-threatening systemic injection reactions. And the safety profile was really very favorable, with long-term exposure, a median up to 21 months, during which time Atumumab was really very well tolerated in these patients with relapsing MS. Now, as I've mentioned before, the systemic injection reactions were seen mostly after the first injection, okay? And then the rate would drop a lot, and then it would be similar between Atumumab and teriflunomide after the third, from the third and onwards. And the imbalance was only seen really in the first injection, which usually is done in the presence of a doctor or of a nurse. And then after that, the patient can start getting monthly injections at home with using a pen, as I'm going to show you in a little bit. So only one patient with a non-serious injection reaction decided to discontinue the study due to an injection reaction. So it was not really a difficult thing to do. Now, how about the dosing of Atumumab? Well, initially we have to load the patient with 60 milligram. And so we have to give him 20 milligram when we start, 20 milligram 1 week later, and 20 milligram 2 weeks from onset later. And then we skip a week, and then he starts getting an injection every 4 weeks. And this, he can start getting those at home. What would happen if they were to miss a dose? They should get it done as soon as possible and then start back on their established schedule from the very beginning. This is the recommendation regarding this. One extra topic that I would like to address is the level of IgG and IgM during the phase 3 clinical studies. There has been no decline in the IgG that was seen all across the Eclipsos trials. So IgG remained the same. However, IgM dropped in about 14 to 15% of the patients. It dropped and it reached a level that was below 0.34 gram per deciliter. So fortunately, this drop was not associated with an increased risk of infections. And during the study, the serum IgM to IgG level were monitored at baseline and then at weeks 4, 12, and every 12 weeks thereafter. So the recommendations would be to get a baseline serum IgG, IgM level before you start treatment, and then monitor your patients periodically, especially if the patient starts having recurrent infections or if you're suspicious of opportunistic infection. And after the discontinuation of the therapy until the B cells are repleted, which should be done to a full extent within 6 to 9 months, as we have discussed before. But the average IgG, IgM level remained well within the range, the reference range with Atumumab, and only in 15% or a little bit less of the cases did it drop to levels where one would have to stop the treatment. So there was no decrease in the mean IgG level, as we have discussed before, compared to baseline, and this is shown here in blue. Okay. However, the IgM levels decreased a little bit over time, but they remained well in the range of safety, as is shown on this slide here. So Atumumab is the first B-cell therapy that can be self-administered at home using an injection pen. It's really easy to manage. It's easy to start. After the loading dose is done, the patient would just go home with their pen and then just push the button in. I don't know if you've had a chance to look at the demo, but it's really simple and easy. You push it in and you don't need hospitalization, you don't need pre-medication, you don't need monitoring, you don't need to worry about a thing. And it is really accessible and something very easy to do. And it is, as I've shown you, extremely efficacious and effective in treating these patients and maintaining them with a good quality of life for a prolonged period of time. So in summary, I hope I was able to show you that Asclepios, through the two studies, 1 and 2, has shown a very superior efficacy when compared to teriflunomide in lowering the relapse rates, in lowering the MRI activity, be it the T2 new lesions or the T1 gadolinium enhancing lesion. It had a substantial and significant reduction in the 3 and in the 6-month clinically definite worsening. It had a very favorable safety profile, and there were no unexpected safety signals. There was no imbalance in the rates of infection or in the rates of malignancies. It remained low in both arms. And with a monthly dose of 20 milligram, very small dose, because of the sub-Q high rate of delivery, we can use small doses. And it would be efficacious and extremely easy to use. And also, it would be extremely convenient because should we want to stop it, the reconstitution or the repletion of the B cells would happen within a few weeks, and it would reach completion within 6 to 9 months. So if a lady, for example, would be treated and she would decide to become pregnant, one could stop the medication, and then after a few months she could attempt and go ahead with her pregnancy. And for the vaccinations, I know this is a very interesting and important topic nowadays. For the vaccination, the live vaccine should be given at least 4 weeks before you want to start the patient on treatment. If you are planning on vaccinating your patient with a live vaccine, you should do it 4 weeks before the treatment. But the dead vaccines were given during the treatment without any further side effects noted. The deactivated vaccines might have a problem building immunity if they are given during the treatment, but this is something that needs a little bit more evidence. And with that, I'm going to thank you and for your attention, and I will be happy to entertain your questions. Thank you.
Thank you, Dr. Naji, for this excellent presentation, very informative. We have more than 456 attendees, so expect more questions to be coming. Meanwhile, I have 2 questions here. So the first question is from Dr. Manu. Can systemic anti-CD20 B cells depleting antibodies eliminate meningeal follicles in multiple sclerosis?
Well, we would hope so. I mean, I don't know that studies were done to look at the lymphoid collections in the brain, but with the elimination of the T2 and with the elimination of the GAD enhancing lesions, I would hope that we would also be able to eliminate the lymphoid follicles that would occur there, or at least it will prevent them from occurring, because we would be really killing the inflammation early on, especially if the medication is used early on.
Great, thank you. Another question from Dr. Lama. Thanks a lot, very well presented. Trouble breathing associated with Atumumab. How serious is it? Trouble breathing with the injection.
Yeah, I mean, there was a higher risk of nasopharyngeal infection, upper respiratory tract infection, and all of that, but it did not pan out to be a significant problem when compared to the teriflunomide. So we might, this is one of the side effects that one might encounter, sinusitis, nasopharyngeal infection, upper respiratory tract infection, but it did not reach proportions that would keep us from using the medication.
So it's not an indication to stop the treatment.
No. You can treat the infection, and that would take care of things. Unless you start to have recurrent infections, then you would be well advised to obtain an IgM level, and if the level of the IgM is really plummeted or really low, then one could consider stopping the treatment. But short of that, there is no need to.
Okay, thank you. Question from Karim. Why there is a step-ladder pattern of medication after diagnosis? What is the real function behind it?
Well, you know, a lot of it would have to do with the way we were taught to do it. You know, so we were all taught start low and go slow, because one would be afraid to harm the patient. But with this disease and with other diseases that have to do with severe inflammation that could and is linked to further progression and disability in the future, I would beg to disagree. I don't know about you, Jihad, but in my practice, I'm very rarely ever starting with interferons anymore. I mean, because of the and I'd like to get your opinion on that, and how are you handling these patients? But if I have a patient that presents with a relatively aggressive form of the disease, I am no longer inclined to give him low efficacy, high safety medication, given that we have plenty of medications now to use, and lots of them with a good safety profile, as we have seen with Atumumab now. Can I get your opinion on that?
Yeah, sure. Interferons are still having a place. It is true we start high efficacy drug from the beginning, but the main indication for highly active disease during pregnancy you want to treat, so interferon can be given. As you know, interferons label indication last year, they were allowed to be given during pregnancy. Second indication is pediatric. In pediatric, we have Gilenia, it's true. We can use interferons, and exceptionally, in highly active disease, we can use Natalizumab. But you are right, we are not using interferon like before, because we have other more potent drugs and less injection side effect and so on. I remember 20 years ago, we didn't have except interferons, Avonex, Rebif, and Betaferon. Now the number of patients really declined because we have orals, we have high efficacy drugs, and we have immune constitution therapy. The question to you, Dr. Naji, can you consider Atumumab as immune reconstitution therapy or not?
Sorry, can you repeat the question, please?
Can you consider Atumumab as immune reconstitution therapy?
Yeah, I mean, of course, because hopefully you would deplete the bad B cells, and then when there is repletion, you would hopefully have to deal with cells that are not as immunogenic or pathological. Let me put it this way. I mean, it's true that for the medication to give its effect, the B cells have to remain low, but it's also true that when you stop, you get a repletion of the cells very, very quickly. And so this is extremely encouraging. And I don't know if in the future we'd be able to see patients that would have been treated with this medication and then to stop it after a number of years. It would be interesting if that were to happen, to look at them and to see how they would behave on the long run, and whether they would keep a certain immunity from the disease or not. But we would need a little bit more time to be able to decide on that.
Yeah, I don't know about the Asclepios study. I mean, comparing high efficacy drug with low efficacy drug, do you think was it fair of Atumumab against teriflunomide?
Well,
this is low efficacy, this is high efficacy.
They could not have used the placebo, you know, they could not have used the placebo. So they went for teriflunomide, which is as effective as the
interferons. Yeah.
So this is exactly what ocrelizumab has done as well. I mean, they compared the themselves to an interferon that is a very active one as well. I mean, so I don't think that there should be a problem with that. They were not going to do a head-to-head with another injectable medication. It would not have made much sense for the patient to get 2 injections. I mean, it would have been extremely difficult to carry a study like this, I would think.
Maybe it is time to compare Ocrevus with Ofatumab head-to-head study.
Are you going to pay for that study, Jihad? Because I don't know who will.
Yeah. We'll hear about it soon. One question, Naji, here. Washout period to shift from Ofatumab to other DMD.
Yeah.
It will be same like Ocrevus? I mean, this is a question.
Well, it should be faster than Ocrevus because, as I've told you, I mean, it takes about half of the time for it to fully replenish the cells. For Ofatumumab, it would take 6 to 9 months for a full recovery. For Ocrelizumab, I would think it would be around 1.5 years. So it should be faster than Ocrelizumab. I would monitor it. I would not use a cookbook. So I would not say 6 months, 9 months. I would look at the levels, and as soon as the B cells have reached acceptable levels, then I would change. Okay, so it could be after 2-3 months, and it could be after 9 months, depending on the patient and how fast they will recover.
Now, you recommended checking IgG and IgM before starting Ofatumab. And if IgM is low, what do? You treat or you don't give the treatment?
If IgM is extremely low, then I would be very hesitant to give the treatment. So, but if IgM is in reasonable levels, I would treat and I would keep a very close eye on that patient, and I would check them back a little bit more frequently than I would do somebody with the more normal levels, you see, because I just want to make sure that they're not going to drop below worrisome levels, and if they do, then I would consider stopping the treatment. The other thing that we need to check for that I forgot to mention in the talk is hepatitis, because if the patient has hepatitis, this would be a contraindication to start the treatment, and they should not be placed on this medication because it could reactivate the disease.
So they should be screened before starting?
Yes, we should screen for hepatitis before we start.
Okay, great. Actually, the strong point in Ofatumab is it is self-injection, monoclonal antibody. Patient doesn't need to come to the hospital, and it's high efficacy drug. So there are very strong points attractive in this medication. There's one question here from Rajar Shi. What is better, Rituximab or Omalizumab? I don't know about Omalizumab.
I'm going to take the fifth on this one, since Rituximab is being used off-label anyways, and we don't have, much to base ourselves on. So allow me not to answer this question, if I may.
Okay, fine. You're allowed. Can multiple sclerosis be completely treated or not? So the question here, cure or no cure?
Yeah, well, we're very close to a cure with medications that are giving us such high rates of efficacy. I mean, we all know that there is no 100% cure for MS, but with the medication that we have now available, we're seeing patients that are stable for years and that have a completely normal or normalizing MRIs, no gadolinium lesions, no new T2 lesions, even normalization and a smaller volume of the lesions that were seen before. So this is extremely encouraging, and I'm really hopeful that within a few years we are going to find a complete cure. But of course, we're getting closer and closer, but we're not there yet.
Yeah, thank you. One question here: what is the best medicine for treatment of multiple sclerosis? So this needs 1 hour to answer it, if not more. So it must be tonight. Ofatumab is the best treatment.
Well, I would say individualize per your patient. I mean, it all depends on the patient. If they are of childbearing age or not, if they are a man versus a woman, if they have prognostic factors that are going to be indicative of a mild disease versus a severe disease. I don't think that the best medication would work the same for two different patients that have two different profiles. So please individualize, look at your patients, look at their comorbidities, look at their prognostic signs, look at how severe the disease could be, and then use your brains to pick the most appropriate medication for that patient. And you also have to listen to your patients, because some patients just want the best medication that would give them the best, and some others tell you, no, I don't want to venture there. I want to start with a relatively safe medication first, and then we'll see. And you can advise the patient, but you cannot make the decision for them, of course. And so you have to listen to them and listen to their needs and give them proper advice. But then at the end of the day, it's a partnership between you and your patient.
Yeah, it is shared decision. It is personalization of treatment. I tell my patient there's nothing called best treatment. There is suitable treatment for you based on your profile, what you have mentioned. Male, female, age, comorbidities, severity, heavy lesion load, EDSS, multiple factors should be considered. So from Sudhir Kumar, nice talk, Professor Naji. Are there any comparison with Atumumab?
No. We don't have, this is the head-to-head study that you wanted to do, Jihad, from the beginning. You wanted versus Ofatumumab, and Sudhir wants Ofatumumab versus Alemtuzumab. So
no, we want B-cell depleting agents together. But okay, one point here, since they are talking about Lemtrada, about Alemtuzumab. I mean, if you deplete the B cells, what happened to the T cells? Is the balance disturbed? I mean, the pathology here.
Well, I mean, in some medications, you deplete both, like, for example, in Alemtuzumab. But I mean, you really need to look into it and keep an eye on it. But in Ofatumumab, no, the T cells were not affected. It was just the B cells that were affected.
Yeah, thank you very much. Thank you. One question from Karim Bakash. Sir, as this group of drugs are cytokine inhibitors, is there any report that these are effective against pandemic of COVID-19? So any positive effect against COVID?
I'm not sure. I mean, I really don't know. I don't know how many patients were treated with Ofatumumab and exposed to COVID. I don't know if this data is available, if Novartis has the data and they would be willing to share with us or not. But I don't want to speak off the top of my head, but I really have no data to back me up.
There were data about fingolimod in patients with MS. And during the hyperinflammatory phase of the pulmonary involvement, fingolimod was effective in reducing the immune response. But I'm not aware of B-cell therapy. They have positive effect. There is generally warning from Ocrelizumab in particular that patients who received it, they were at high risk of hospitalization, but not mortality. But I think we have more data now reassuring about B-cell therapies in general.
Yeah, the problem is the formation of vaccines. I mean, some patients that are treated with this B-cell therapy would have difficulty mounting good immunity when they are vaccinated against the medication. This is why it would be advisable, if you want a patient to be vaccinated and you want to start them on treatment, to do it beforehand. So give them the vaccine before you start them on treatment if you have the luxury of time.
But you know, many of the patients will be already on medication, and still we have to vaccinate them, even a 50% reduction in the immune response. It can be acceptable.
As I've mentioned, the dead vaccine were given during the treatment, and no problem occurred with that. The attenuated, we're not sure that they formed a good immunogenic reaction to the vaccine or not. The live would not be recommended during the treatment.
Yeah, great. So one question from Akindi. What is good plasmid that marks the plasma membrane for B cells? What is a good plasmid that marks the plasma membrane for B cells? I can't understand this question.
I don't know. I really don't know.
Yeah, okay. Either, I don't know even. Is there any drug to target memory B cells?
Not of Atumumab. It does not target the memory B cells as we've discussed before. So this is not going to be affected with this medication.
Yeah. One question from Alia Zuhdi. How long will the effect of immunization in the body after vaccination? And when should get another if COVID positive? So if a patient got COVID, when should he be vaccinated?
If it's that vaccine, they should. The recommendations are to wait 3 months after the COVID infection to get the vaccine, and this should not be affected by the treatment. If it's an attenuated vaccine, I would do the same. If it's a live vaccine, I would have problems giving it again the same story. But usually, what we're hearing from experts is wait until you are 3 months away from the COVID infection to get vaccinated. And whether you are on treatment or not would not make any difference if it's a dead or attenuated vaccine.
I think there was some changes in this patient got COVID when to be vaccinated. In fact, we have many staff got COVID, mild COVID, and they were recommended to be vaccinated, to receive the vaccine 2 to 3 weeks after recovery, if they recover fully. But at the beginning, we used to wait 3 months after having COVID. Now we are more flexible, we are giving it early.
What do you mean recover fully? So how do you follow up recovery, Jihad?
PCR should be negative, X-ray chest negative, patients back to normal, no flu-like symptoms, back to normal. But so in this situation, they can get vaccinated.
Patients that have chest X-rays that are negative, and if you do a CT chest on them, they still have very active lesions, and it is taking them about 3 to 6 months to recover from those
then
lesions.
They should not be vaccinated.
Yeah,
I'm talking about mild.
Detect those by doing a chest X-ray, unfortunately. You see, so this is why I was asking you, how would you monitor for the full recovery? Because I would be very careful about giving the vaccine that early in the game. I mean,
this is the new recommendation came from the experts about how those having COVID recover fully, clinically, radiologically, blood test, everything, then better to vaccinate them early. It is true, we used to wait 3 months at the beginning because we didn't have data. It seemed there's some accumulating data or emerging data supporting this. But again, it should be case by case. Not all patients should be vaccinated. You are right. Now, question from Muhammad Al-Mirza. Prior to Ocrevus, we don't need IgM level as well, only IgG levels. So this is comments. We check IgM, not IgG, prior to Ocrevus. Well, if you check IgM, you have to check IgG. It's the same blood test, you know.
Yeah.
Okay. Let me check in the. Some people put the questions in the chat box. Is Atumumab a reasonable option for pregnant patients? Of course not. And Dr. Naji mentioned this. You should wait 3 months after stopping it to get pregnant, isn't it?
Yeah. At least 3 months. I mean, you should wait until you have a recovery of your cells. So it would be at least 3 months, anywhere between 3 to 9 months, depending on the rate of recovery.
Yeah, because for Ocrevus, we should wait 6 months to 1 year. Exactly. According to the European, to the American. Atumumab, we wait 1 year before getting pregnant.
Yeah.
Now, I don't see any questions here, but let me chat with you. There are many thanks about the presentation and the questions. My question is, which is more important in the pathology of MS? B cells, T cells. We learned in the past it was T cells. And later we say B and T, and now we say B cells. What do you think as expert neurologist and pathologist in this area?
You know, I would be hard pressed to say one over the other because they work in combination. But the one thing I would say is that the results that we have seen from B cells therapy are spectacular. I mean, both from the relapse rate as well as from the MRI criteria, we've seen an almost complete elimination of the gadolinium lesions. And we've seen a tremendous decrease in the new T2 lesions. And we've seen significant decreases in relapse rates when compared to the treatments that we were having before and that were addressing mostly the T cells. So I would say, I mean, that B cells are a very important player in the pathology of MS. Of course, had it not been for the T cell, maybe they would not have such devastating effects. So they work in tandem, and hopefully by addressing both cell lineages, we will be able to finally get a cure for this ugly disease.
Thank you. Great. Do you do some workup before starting of Atumumab? Any required specific workup?
Yes, you need to, as I've mentioned, you need to check for hepatitis. You need to get an IgG, IgM level, and then the usual, I mean, cells. But you will not need to follow them later. It would be an elective thing to follow them. But I usually like to have them just for my obsessive compulsive nature to be satisfied that everything is okay. So I usually get a profile with CBC liver function test, hepatitis, IgG, IgM, and then I would follow up the IgG, IgM. And if need be, if there are recurrent infections, etc., I would do more. But they're not required. I mean, the only thing that is needed is the IgG, IgM and the hepatitis before you start. But the rest are elective, they're not needed.
Great. So no real burden of monitoring. Do you check B and T lymphocytes before starting? CD20, 90, and these things like Ocrevus?
No, I just do the IgG, IgM.
Okay, great. I don't see any questions here. Though some participants raise hands, I don't know what does it mean. Are they allowed to speak? We are 500 almost. I don't think we're allowed to use the microphone. So for those who raise the hand, they can type the questions in the Q&A. Dr. Naji will be more than happy to continue answering. Yeah, okay, there's one question here. No mics allowed, yeah, no microphone allowed, okay. You mentioned something very important, Dr. Naji, about the difference between sub-Q and intravenous injection.
Yeah.
So here we are dealing with sub-Q injection, not intravenous. So what you exactly mentioned, it's more effective if it's given.
Yeah, the rate of delivery for both ocrelizumab and for ofatumumab is higher when you use it subcutaneous compared to IV. And the rate of recovery is higher when you're using it sub-Q versus IV. So it's to the advantage of ofatumumab really, because and this is probably why we can use much smaller doses with ofatumumab and reach very good results as well. So it was interesting to look at this from the pharmacological standpoint. It was interesting to look at these studies.
And in fact, if you see the pen itself, the injection pen, It is a highly advanced technology. You don't need to press. You just remove the and then put it. Then you hear 2 clicks. The first click is the injection. Second click, it stops. When the injection is gone already subcutaneously, you need to see only. And then when the second click happens, remove it. It uses sensory
and it is very fast.
technology.
Much faster than even the demo pen that is used to show you how to do it in the clinic. I mean, it's really very convenient.
Yeah, correct. So there is one question here. Is it recommended for MS patient to be vaccinated against hepatitis B generally or before the treatment?
What do you do, Jihad? I just want your opinion before I give them mine. How do you approach this issue?
Yeah. We screen patient before starting all monoclonal antibodies for zoster, for hepatitis, especially hepatitis B. And if there are no antibodies, we vaccinate them before 6 weeks, 4 to 6 weeks before starting the treatment. So I think here it will be the same. I don't know what's your approach in this.
No, I do the same as well.
Yeah. We have many patients who they did not contract chickenpox, and the zoster antibodies were negative. So we vaccinated them, and then they started whether it's monoclonal or Mavenclad or any high efficacy drugs.
Agree.
Yeah. Thank you very much. I don't see any more questions here. And I finished my question. Do you have any question to ask yourself?
I hope this was a topic that you enjoyed listening to. I appreciate your attendance. It's already 9:15, so I'm not going to keep you any longer. Go enjoy the rest of the evening with your family, and hopefully we will be meeting again soon for some as interesting topics. Thank you, Jihad.
I'm sure.
Thank you. Organizer, sponsors for the opportunity.
Thank you, Dr. Naji, for your excellent presentation and questions. Thanks for the Novartis, for the organizers, MCO, and for the Emirate Neurology Society, Dr. Suhail. And before all, thanking all the audience for their interactive sessions. We already reached more than 450. So all of you will receive your CMA certificate, and the organizers will be communicating with you via email. So thank you, Naji, again, and wish you all good night. Enjoy your night.
Thank you.
Thank you. Take care. Bye-bye.